I'll wait for the slides to come up, but really I wanted to thank the panelists. I'm really going to ask them a bit of hard questions because it's about how do we make sure we're getting answers to some of the simple and then complex problems that we have. I will tell you that I'm going to make a bit of an apology at this outset, is that I'm looking for really practical treatment plans based on your experience with specifics, dosages, durations, timing, extent, and I'm going to apologize because I'm not really seeking consensus. I won't ask all of you. If the answer is the answer, we don't need to say it 4 times, but I am interested if you disagree with what an answer you've heard. And we're time constrained. We have 30 minutes. I'm going to try to get through as much content as we can, and so we're going to try to see if we can make that happen. Again, a congratulations to Doug and Greg for putting on what I think is a world-class course in a world-class venue, and I think that the Seattle Science Foundation should get a big kudos as well for how that lab is. I have not seen a lab that well equipped and set up, and so congratulations. Great undertaking, and to be in the 11th year is great. My thank you, because I don't know if Greg saw these slides, to Greg for really including me as one of the local faculty, and to Ian and Sanjay and the people I see here every year, Amy, that I love being down here and really value the insights and opinions I get here. An acknowledgement to the fellows who put together some of the cases that you'll see. My current fellow's from Columbia, and she helped me with a lot of the images and videos you're going to see today, so I wanted to thank them all. Sinus disease is complex, and from 2012 when an EPOS came out and it was just with polyps and without polyps, to 2020 and 2021 for ICAR, where Dr. Woodworth showed us this nice description of primary CRS and secondary CRS and broken down. And really, we're going to try to focus on this diffuse primary CRS, which includes type 1 or type 2 and non-type 2 inflammation, because it's 80-90% of what we see. That may not totally be true if you're not including things like odontogenic and fungal balls, but it is that diffuse inflammatory problem. Really, it gave us an idea that there's a difference between that eosinophilic drivers and the non-eosinophilic or neutrophilic drivers, and that there's some mix. There's some things that don't fit easily into those. But how do we clinically distinguish those? And we've heard a bit about it, but I wanted to ask the panel when I start, is differentiating between eosinophilic chronic rhinosinusitis and non-eosinophilic, which I call neutrophilic, a part of your practice? And if so, how do you do it? And then do you use that information to change your management? So I'll start with Peter, because he's on the end. What do you do is it a part of your practice to distinguish that?
It is, and I think as we start thinking about sinusitis in this different way, this is how we try to frame it. Part of it is look at it. Look at the pictures that you have. And here it's actually fairly clear. But this also kind of gets you thinking, is this more of an inflammatory versus, eosinophilic driven versus more of a neutrophilic driven? Second thing is looking at the patient in general and the rest of their disease processes. How is their asthma? How are their out? Things like that. Dr. Woodworth mentioned lab works and things like that. That is helpful. I do something similar where I get baseline lab work. So if you get to some of the differentiation, that's a start for me. And then the last thing is, what are the things that have tried as part of your history, which you just put up there? What have you tried? What's worked? What hasn't worked? Things like that.
I think that's a pretty good answer. I kind of framed it as 4 things that I think we should think about. History, which Dr. Manis has done a nice job of kind of describing some of the things, blood work, and endoscopy, and then tissue biopsy, which is the one that I kind of maybe should include a question mark. From a history standpoint, I agree with you. There's some pretty good ideas about who are those type 2 patients, and I actually wanted to give a shout out to some Canadian authors about kind of comparing eosinophilic and neutrophilic, and those early onset asthma young people who have bilateral polyps present with smell dysfunction early in the disease versus the late onset mucopurulent discharge. We can tell those, even just talking to the patient initially from their history. I like the idea of the blood work, and I won't rehash it because I think both Dr. Manis and Dr. Woodworth have done a good job of identifying eosinophils and IgE as sort of some of the baselines that we can use.
So, hey, Dr. Janjua, if I could interject.
Please do.
So how does that change your management? Let's talk about this. I have a mic, thank you. Yeah, permanent mic here, of course. Yeah. You can't get away from me. Not Mike. I used to have a panel at the university, and every single polyp patient, inflammatory patient came in, we get the panel. And I do think it's helpful in many cases if someone is needing revision surgery for recurrent polyps, if they have really severe asthmatic disease as well. But let's think about, I don't want everybody to think that you have to get blood work on every polyp that walks into your clinic. I think a first-time polyp patient, it's probably not going to change your management. Or let me rephrase that, it's not going to change your management.
But you've already identified them as type 2 then, if you're telling me they're simple polyp patient.
I'm going to assume they're a type 2.
I think that's
Correct.
fine. But you use your eyes to do that, just
yes.
like Pete said. That
now, the one thing I'll add is, the reason for some blood work that I do get in revision polyp patients is that it really emphasizes to the patient this is a systemic disease. It helps set up the expectations that, just like asthma, you're going to have to treat this on a daily basis. It's not just isolated to your sinuses.
Good. I think those are good comments. And I think that what I use it for is, exactly as you allude to, failures. It gets me. And why I've started to use it maybe more at the outset is learning myself and then predicting failures. So when I see some of the eosinophil levels that are sky high, like Brad showed, that I can tell that person, listen, we're going to have a difficult time controlling it. It's not going to be surgery and done. We're going to have to start to think about odds ratios of failures when we're talking about it. This is a plug for just a bit about tissue differentiation, is that we've adopted a histopathology report that our pathologists have bought onto. And so instead of just getting chronic inflammation written on my path report from the OR, we've got them to comment on, eosinophil counts, basement membrane thickening, fibrosis. Those are the things that lead to failure. And I think that that's exactly what I want to know so that I can counsel them when they come back. Listen, we're going to have to be really dedicated to our topical therapies because I think that you have a risk of potentially failing in that dense fibrotic patient. The other thing that I think I use is that this created an algorithm for me, is that there are some things that work in the eosinophilic population and some things that work in that neutrophilic population. And we used to just use our eyes, but that's the art of rhinology. And I would still say that's what I use the most, is that those pictures in the office about trying to differentiate what they are, I wouldn't say I do that through blood work. I do that through my experience about it, and then it leads me down treatment arms. Now, those treatment arms come with a whole host of things that can be effective, but if you start using treatments that are geared for type 2 inflammation in the non-type 2 patient, you're destined for failure. And so that's the only reason I say that it helps me, because it helps me put them into one of two categories, at least to start trialing some of these things. Anybody any comments about this particular slide about how it helps me clinically? Because Greg raised a good point. Does this seem to make sense? I think that the thing that is at the end of it all is most of these patients do well with surgery. So I don't want to take away from the fact that they need surgery. This is in the back of my mind about how can I predict people are going to fail? What ancillary or adjunct treatments do we need to move past that? I'm going to start with a case because I think that this will help us frame some of it. Some of it is basic and we've gone over, and I'll try to speed through. This is a 52-year-old male who has a 20-year history of obstructed nasal breathing, rhinorrhea, decrease in the sense of smell, facial pressure in the forehead distribution. Their Len-Mackay score on CT is a primary 14. They've had no previous medical management, and their endoscopy reveals a moderate degree of edema throughout. I don't know why. That video should play, but it then give you an idea about fairly substantial. I scored it as a 14 out of 24. So in summary, 20 years of history, primary 14, moderate degree of edema on endoscopy, no polyps, no purulence. I guess my first question I think has been answered. Initial medical management, I think we heard yesterday, nasal saline irrigations, intranasal corticosteroids, maybe some systemic trials for various reasons, some payer related, and some treatment related. I guess I want to kind of skip that piece unless someone has something to add about that initial medical management. Timing of follow-up. This is a question I get a lot. So Vince, I'm going to take you next, is that what is that initial timing of follow-up? You start someone on intranasal corticosteroids and saline nasal irrigations. When do you have them back to have the next look, visit, conversation?
So typically about 4 to 6 weeks. Actually, one quick point I wanted to emphasize what Greg said that I really want to make sure everyone really drives home is the sense that what is really emphasizing that this is a biologic disease for people with type 2 disease, because a lot of the failures we see, people have had, granted we always could improve on their initial surgery, but the reason they failed is because they didn't do any subsequent, medical therapy, right? And as Greg says, really say, hey, look, this is a biologic disease. And he emphasized by doing the blood work, but I always have like the come to Jesus talk to him and say like, hey, they thought they were going to have surgery and be good. And unfortunately, the initial surgeon, they maybe didn't emphasize that. So they just thought, oh, once I get my polyps taken out, I'm good.
I like the idea of setting expectations.
Yeah. So then you tell them, like, hey, no, this is going to be a lifelong management. And they finally get it, But anyways, sorry.
Timing of follow-up evaluation was 4 to 6 weeks.
Yeah.
And why do you pick that timing?
Well, I mean, it's typically, I think there's diminishing returns past that. It's not like, oh, you see them, and if they follow up in 2 months, like, oh, there's such a big difference from.
Does anybody do anything different than that?
Same.
Okay, I do mine a little bit longer. I think that the initial 1 month is maybe not enough for my intranasal corticosteroids because we know that there's a bit of a lag in terms of how much better people feel, for sure. Maybe its effect on the tissues. I think if you got past 1 month, you're doing fine. I do the 2 months, and I don't know if that's just enough time for my topical therapies to work. When would you make a decision to proceed to surgery, and when would this decision be made? Amy, I'm going to ask you that at this picture, despite the idea that you're going to give them topical therapies, would you make this decision about surgery here or at follow-up, or what's the best play?
So I think I know at this visit that they will need surgery, but I'm not going to offer them surgery at this visit. Yeah. And so we're going to give them medical management just like you guys talked about. My follow-up is a little bit longer than yours. They're going to come back and we're going to talk about how they're feeling. And then they're going to get options. And so all of my patients actually get the same options every time. I tell them we could do nothing, and I tell them what's going to happen if we do nothing. And this is where it gets to it's a chronic disease, right? Your disease is going to progress. This is what's going to happen to you if you do nothing. Second option is we can do more medical management, and now they have a taste of it. So like, what is medical management? And this is what we can do. If you don't want to have surgery, and certainly they don't have to have surgery, right? It depends on what their symptoms are and how they come back and how they feel the medical management has worked for them. We can continue with medical management, and then I can tell them what that's going to look like. So how are we going to medically manage you if you decide you don't want to have surgery? And then I say the third option is surgery plus medical management. And surgery always goes with medical management because you can never escape the medical management portion. And then I describe to them what surgery is like, and then what medical management after surgery is going to be like, and why medical management after surgery is going to be so much better than it's going to be without surgery.
Okay, I like that, setting expectations ahead of time, that there's a dedication to medical therapies. This was about nasal irrigations, about high volume, just maybe creating an improvement. I put this in there as a question. Does anybody use exhalation delivery systems, and has comments to make for the audience who may not have tried it?
I have used it. And in disclosure, we were part of the trial that was doing this, and at times I was stunned how patients felt better and looked better. Because honestly, I heard this and I was like, come on, this is not, you're closing off now. Come on, I'm not buying this. But hard to get covered. And it's not, again, I can't pick out the people that I would say, oh, you will get better on this. So it's not something I would routinely do. It's probably something that I would maybe offer if we're having that discussion saying, I don't want to do surgery. What we're doing right now doesn't work. What else you got for me? And I say, well, we could try this if we can make it happen, and we can see, just because it does offer a slightly different option.
We don't have it in Canada, which is why I was asking you, and I'll ask Greg his opinion as well. Go ahead.
I'll give a slightly different opinion. Disclosure, I'm on their scientific advisory board, but because, we fight all the time on the advisory board, so it's not like we're pro it. Admittedly, I'll use it on my failures. If people can get by with steroid rinses, then I'll go with that. But also those patients who travel a lot, or those patients who they're not compliant because they don't want to do steroid irrigations because it's a pain in the neck for a lot of people. Some people love it, a lot of people don't. It's a great option. And the company, for non-government-based insurance, for commercial payers, they do have a program where they really minimize the amount of money the patient has to pay out of pocket. You just, like all these other things that are challenging to prescribe, the biologics, Sinuva, Xhance, if you have a system in place in your office where literally for me to write the prescription, I write the word Xhance on a piece of paper and I give it to my team and magic happens and they fill out the paperwork and it's done. It makes it easy for me. And I would encourage you to try to use that because I think it is the research has shown that it decreases polyp size, it decreases CRS acute exacerbations, and that paper's being published now, which is an exciting thing. You think about all of our patients that we do great surgery on, they still have exacerbations, and this is something that can help.
I put it in there to talk about education. Part of my conversation when I first meet them and talk about this disease is about the necessity to use them, but you'd be surprised at how many people do it poorly. And so intranasal corticosteroids are not used well unless you're taking the time to educate them about how to get it into their nose without the sniff, which kind of defeats the purpose because it all just goes between the inferior turbinate and the septum and goes to your nasopharynx like almost instantly. Because if you ever use any of the ones that have rose water or azelastine component ones, they tell you it's bitter. I'm like, that you tasted that like right away? Yeah, well, that's not very good because it's not going onto your nasal mucosal lining at all. I thought this makes it a bit more idiot-proof in that it's going to distribute into your nose pretty evenly, and so I thought it was a good way of kind of bridging that education discussion. I elected to start her on top peripheral therapies and reevaluate my office in 2 months, like I said. 2 months' time, the symptoms were improved, but not completely, and together we decided to proceed to surgery. I was going to ask a question about preoperative medication regime. What do you use preoperatively, and is it always the same, or does it change based on patient factors? I think I'm all the way back to Dr. Manis.
You're talking about what am I putting them on, prepping for surgery, or what am I utilizing in the decision-making process before that?
Prepping for surgery. If I've already made that decision for us, in this case, sorry, what do you use? Do you use anything?
I don't typically.
Okay.
I don't typically put them on oral steroids. Some people do in polyp patients because it can decrease bleeding. I tend not to. And I think I'm just trying to limit the steroid that I'm delivering at that point, because I definitely want to be using it afterwards.
Do you always use it afterwards?
Not always, but frequently.
What settings make you use it afterward?
I'd say it's more the settings where I don't use it afterwards, and it's mostly some sort of contraindication to it. I'm really careful with diabetics. I mostly do use it, though.
Does anybody have a different paradigm where they use preoperative medications regularly?
Not regularly, but bad polyps. It just makes everyone's life better.
And that, from
Just
a
5
practical
days or
standpoint, so you can clarify for the audience, what does that mean? It makes...
Less bleeding, more room for visibility.
So you can see better because it's bleeding less. It makes surgery take shorter maybe because you can see better. It's bleeding less. They feel better because they bled less.
Yeah.
Okay.
People with brittle asthma. So especially with your Samter's patients, I've had patients upon intubation go into status asthmaticus. And in the post-op recovery room as well. And so I think it's really important to be pre-treating those people with prednisone.
Okay. I'm going to give you mine just because it's a bit different. I pre-treat everybody, and I do it on the basis of how severe that inflammation is. That I think if they have a little bit of inflammation, they'll maybe get 3 days just to help me with the bleeding and the visualization. If I think there's more substantial, 5. If I thought it was a really bad AERD patient, maybe I'll use 10. It's pretty rare I've ever done that, but I do that. And then I do the same thing in my postoperative period, that I utilize it based on the degree of inflammation that I identified.
And that's in all comers. Polyps doesn't. I mean, obviously, but I mean, it's all types of disease processes.
Good question. I think that'll eat up a bit more time, but I try to separate them out into who it is. So if I believe this is a chronic purulent or neutrophilic driver, I will use less steroids and longer antibiotics pre. If I think it's an eosinophilic, it's less antibiotics and more steroids pre. So I tailor that to what I believe was the different types. Another piece about why do I use a differentiation between eosinophilic and non-eosinophilic? Because I do things differently in the prep for surgery.
To use your guidelines and give specifics for the audience, in my practice, I'm talking about 30 milligrams of prednisone for 5 days in a polyp patient. There's been a couple research studies, as Vince mentioned, that shows it decreases bleeding, improves visual field, but as Amy mentioned, really importantly, it helps them get out of the recovery room faster and have an easier recovery because of their asthma. And the anesthesiologists are much happier.
I do the same thing, and part of the other reason I like it is anybody who has asthmatic, I don't want them showing up the day of surgery and being canceled by the anesthetist because they had a flare-up, and so that now I've set them up to not have a flare-up because I've treated them preoperatively. The next question is about extent of surgery, and so that's a challenging one on its own. I think, are we at, Dr. Chan? Extent of surgery. In this particular case, what extent of surgery or sinus aeration? And I know that could be its own 30-minute panel, but give me an idea about what you would be performing for this patient.
I'm kind of curious about that little bone chip in that left maxillary sinus and where we think that might have come from. Did they have a root canal or? or is it just
So that we don't
calcified
get
secretions?
segued, let's say that is nothing, and I don't know.
Yeah, no, I do. As we talked about before, it'd be wouldn't be large hole surgery. It would be pretty limited to maxillary and ethmoid, and just maybe exploring the opening of the frontal.
And so you're maybe going to treat this frontal.
Yeah, just kind of winging it a little bit, because sometimes it looks better or worse than how it looks in the scan, and you can kind of make that decision kind of on the fly, I think.
Anybody else have a different approach, or would that be pretty much consistent?
I disagree. I would definitely take. Sorry, I keep forgetting to do this.
Yeah, definitely
I would definitely take the frontal. There's no doubt. There's disease in the frontal ethmoid recess. That is by far the most common area where the polyp recurrence originates. And I know I need to get topical steroids up into, especially that frontal that we're looking at, right? Looks like the left frontal that we're looking at. Now, you could argue, well, the right frontal looks pretty good on the axial view, bottom right, but if you look at the coronal, you still see that's a posterior extension of the frontal recess, and again, I would take that out. What I would leave, it does not look like they need a sphenoidotomy on this left sphenoid here. But I would want to see what the sphenoethmoid recess looks like. If there's polyp disease in the sphenoethmoid recess, same thing, I'm going to open up that sphenoid sinus.
I think that was more in line with what I did as I completed the entire aeration of a complete ethmoidectomy, maxillary antrostomy. I made it fairly sizable because I'm a big hole surgeon too, I guess, and did perform a draft 2A frontal sinusotomy on both sides here, taking into account the frontal recess disease. I can't remember their sphenoids, but I would do the same thing. If I saw disease at the os, I would open it, and if I didn't, I wouldn't. These are some.
Let me just, and not that there's no wrong answer.
No,
right?
I don't think there is.
It's just the thought is, and good chance this patient, if you didn't do the frontals, decent chance that they would get better. Decent chance. I just don't want that patient to come back and say, well, Dr. Davis, why didn't you do the frontal sinus when I clearly had frontal sinus disease on the CT scan that you showed me? That's one of the reasons to be thorough with that.
For me, it's about revision rates, and I guess in our access to care system is not as easy as yours. You could take them back next month and fix that frontal that you didn't aerate and it needed it, or maybe it got better on its own. But that takes me a while to get into the operating room, and estimates would suggest that revision rates for sinus surgery are high, and there's a whole bunch of reasons. It could just be disease severity, but there is inadequate aeration of those sinuses and maybe just inadequate penetration of topical therapies. And so for me, in my hands, I've had identified very little downside to too big surgery. I have identified the downside to too little surgery, and so comprehensive primary surgery is, I think, something that I have been stuck with, and I think there's reasonable data to suggest lower revision rates in the full house FEST population versus a polypectomy anterior surgery, and so I'm a proponent of complete surgery, whatever you want to call, complete aeration of those ethmoid cavities.
Just to give a counterpoint, I would say this is like an argument with rhinologists, right?
Yeah.
But I would say for the general ENT population, in that patient, to do a good ensinectomy, to do a good ethmoidectomy, to do good maxillary antrostomies where you're incorporating the natural os with the posterior fontanelle and you're making a nice wide opening. If you do that, I think most of the time your patient's going to do well with appropriate medical management. So I think it's okay for the general ENT not to go too crazy.
And a lot of times when you're doing a complete ethmoidectomy, in essence, you're pretty much doing the front. You're pretty much doing the frontal. It's a matter of the degree of how much are you actually instrumentalizing the frontal outflow tract, but it's kind of a bit of semantics.
Then I think we're on the same page, because I would call that operation a complete ethmoidectomy. And I think what happens is the frontal gets done that way, the max gets done that way, and so I don't think much more than that. I'm going to go to another case, and hopefully I can get through it. This is a 18-year-old male who had moderate asthma and a 2-year history of nasal obstruction, discharge, hyposmia. He had ongoing symptoms despite topical therapy. When I examined him, he had global polyp disease, a severe mucosal edema. This was his scan. when I scored it as a primary 18 out of 24, fairly significant disease. I'm going to tell you, I took him to the operating room and performed bilateral endoscopic sinus surgery, a draft 2A frontal sinusotomy, and nasal septal reconstruction. He did really well postoperatively, significant reduction in his symptoms. He was asymptomatic and did great at a year when I kind of let him go. Told him to continue on his topical therapies because of his phenotype and his type 2. 2 years later, after surgery, he came back. His symptoms returned. He said he was good with his topical therapies and he was doing a good job. And he had severe recurrent polyp disease, both medial and lateral to the turbinates. And now this 20-year-old, because he was 18 at the time, I repeated his CT scan. It looked like this. I couldn't see partitions that I really had left behind. I think there maybe is some areas of scarring, which I haven't done as good a job right at the skull base, but this is just inflamed mucosal edema, recurrent polyps. He was a revision 19 now from a primary 18, and I thought, what did I do here? And so I guess my question is, for the panel, is refractory. I'm going to call this refractory eosinophilic CRS, because this is where I think that I've led this panel. What do you do for this patient when you meet them in terms of he's doing budesonide irrigations? I think I said BID. He may or not have been using a nasal steroid spray in the middle of the day. Anything that you would suggest? Where did I get to? Amy? Is it Amy now? Sorry.
Yeah, I mean, I think everything on there.
Okay. Tell me, practicals for them about what does that mean?
And so when this person comes back, I would say the number one thing they need is steroids. So I mean, they need a steroid taper right away. That's going to push the polyps back. It's going to start controlling disease. And sometimes you get like a really good responder, and people are have varying responses to oral steroids. But in this young patient like this, I am going to be thinking about biologics, and I want to make sure that he's been tested for cystic fibrosis as well. But definitely biologics. I mean, I've seen incredible responses to biologics, and I think that after you get the response, you can start. We've been talking among us that we've been stretching it out where patients don't have to have it every 2 weeks, so you can do it every month, and some patients every 6 weeks, and so now you're decreasing the cost of medication by half. And so if you get people who really respond well and they only have to do shot, once every 6 weeks, that's a great thing. So, but yeah, all of these things.
So a little bit different take on that.
Good.
You don't need it.
First, I don't want to question the integrity of this 18-year-old, but I think it's a challenge to think an 18, 19-year-old is going to be irrigating twice a day religiously. That being said, this is a time to say, look, it's like an asthmatic using an inhaler if they're holding their breath. The topical steroids are not getting where they need to go in this patient. So you can reset that with a course of oral steroids, like Amy said, and then this is a perfect patient, if he's a reasonable patient and non-anxious, to do an in-office polypectomy. You did a beautiful surgery. There's no septations left. All you got to do is take your debrider and clean that out, and the topical steroids may work again. I would give them the option of that prior to condemning him to a $30,000, $40,000 per year medication, even though they work for a lot of patients. But I think shared decision making is really important, especially in this day and age, and using that term, I want to make this decision with you together, not for you.
I like that both those answers are right in my mind. I think you're totally right, and there you have so many options at your disposal. How you piece them together, I don't think matters, but getting medications in is the key. Whether you do that with some oral steroids to shrink the polyps and get your topical therapies to work better, whether you do that with a polypectomy to get the medications to work better, whether you combine those, which I think what I did here to do that, and then thinking about even bigger than polypectomy, is there a role for revision surgery? Because I think that we know that biologics work. We saw this data before from Drew in his very great talk this morning. The question is that cost effectiveness versus the clinical utility.
Let's go back one slide though.
Yeah.
How well do they work? Right? They decrease polyp size on a 4-point scale by a 1.5.
I'm not worried.
They dramatically help symptoms. They decrease need for surgery. They improve smell function. But
those data pieces
you
are
showed
more important.
a big polyp burden in that patient. He's still going to have a polyp, likely still going to have a polyp burden in that, especially along the skull base and frontal recess. So.
Interestingly, in my counterpoint to that is I agree with you. More of that is important to us than it is to them. They don't care what the polyps look like. They care that they can smell their food, that they breathe better. And so this never made sense to me as an outcome. It doesn't matter. I don't want to move out of the camera. It doesn't matter how big your polyps are. It really matters how intense the inflammation around them is. And so I make not a lot of decisions based on that, but I like your office polypectomy when the inflammatory burden is. You're decreasing the inflammatory load. You're taking away all those inflammatory mediators which are driving this disease. And so then the cost piece was what you were alluding to, and that in many places, including the UK who drove this, Cochrane, is the current high costs are limiting their use. And so apart from the states that we have troubles accessing these medications, and we think that the cost of biologics should matter, and you've got to take into account some of the other pieces of that puzzle to figure out what it is. And then, so when I'm asking myself about biologics is, well, what's going to happen? What's going to happen when they come off? We know what happened when they came off at 6 months. What's going to happen when they came off at a year and the data they haven't shared with us? And therefore, what do we do about the dose? Can we start to reduce it? If you did their polypectomy and had a way less inflammatory load, could you use a lower dose of medication? What about the long-term safety? And I will say that Drew did a pretty good job of showing us that these are safe medications, particularly the ones that have been around in asthma for a very long time. We know that the disease profile of stuff like mepolizumab has got 10 years of asthma data, 250,000 patient years. It's safe by and large. I don't think we have dupilumab data that's that long. The remainder of ours was going to talk about advanced aeration surgeries. So when you have people, like in my situation, who don't have third-party health coverage for drugs and can't get on biologics, because I think if we believe that he's doing his topical medications well, and you can't use oral steroids forever, but if you don't have a plan that lets you afford biologics and you can't pay for it out of pocket, $30,000 a year, that was when the more surgery came into play. But we are at the end of our panel, and so that piece we can either continue with or leave for another day about what does advanced aeration surgery look like. I elected to take him back to the operating room and do something different, not the same thing, because I could have done that polypectomy in the office. And to try to make those decisions, I used some of the features that we saw, polyps everywhere in the olfactory cleft, and I elected to think about his frontal actually isn't a problem. He has a very good AP, but he has a really narrow kind of nose and a narrow area that's affecting topical medication delivery. And so I resected his bilateral middle turbinates and opened his frontal sinuses without creating a septectomy between to try to get an outcome that I thought left him with good longevity. And I've been continuing to follow him. He's done really well because his topical therapies can get to where they need to go. And I think that was part of the trouble. And his smell, which was the big elephant in the room, is his smell got better because he couldn't smell at all before. And I took out 20, 30, 40% of his smell fibers, but now he's rocking half of that. So he's a 4 out of 10 because he was a 4 out of the 60% of his smell fibers I left there. And then the conversation can turn to, should I have done that at the outset? And I think that's a harder conversation and one for another day. Thank you to all the panelists sharing really practical pearls about how you manage these patients. I appreciate the candidness and the upfrontness about that.
Thank you.